My name's Steve Gardner. I'm the Managing Director of Healthcare World, and I'm very, very pleased to present this afternoon what I think is going to be an absolutely fascinating conversation about the development of healthcare in the Middle East, particularly around the ways in which public and private can come together for the benefit of the healthcare system. In my home country, in the UK, we tend to think of PPP as being purely an infrastructure model. I think that what we're probably going to be talking about today is a lot more the benefits of bringing public and private together for the benefit of the whole healthcare system. And that could be anything from the development of a digital health program to public health messaging. There are so many ways in which public and private can work together, and probably no better example of a will and a desire to bring the two sides of the system together. Three sides, really, because in many ways it's the supplier, it's the health system themselves, and the insurer. But there are no better examples, as I say, of areas of the world where there's a will to do this than there is in the Middle East. So our chair today, and anybody who saw our digital session last week will know what a whirlwind she is Nitty Paul from KPMG. So without any further waffling from me, Nitty, it's over to you.
Hi, thank you, Steve. Thank you very much for introducing me as Whirlwind. Some people call me a Whirling Dervish, but never mind. It's really lovely to see you all here. It's really nice to be with the Middle East panel, where I've spent quite a lot of the last few years wandering in and out, and I know some of you. Public-private partnerships remain an active subject in most countries that I go to, but a lot of countries don't often make a success of it. So I'm hoping that this panel is going to give us some great insights into public-private partnerships. We have a fantastic panel, and we're going to be asking them questions. I'd love to hear from the audience. We try to make this very interactive, so please keep your questions coming into the chat box. I will pick them up and I will put them to the panel as we go through the conversation. So again, without further ado, I'd like to introduce the panel to you. I'll start with Dr. Ibtisam, if you don't mind.
My name is Dr. Ibtisam Al-Bastaki. I'm based in Dubai. I'm a physician in background, but at the moment I work as a director of investment and PPP, as well as I handle all the healthcare projects within Dubai Health Authority.
Thank you, Dr. Ibtisam. Stan?
Hi, I'm Dr. Stan Shepherd. Lovely to be on the panel today. I'm the founder and CEO of a company called Instant Access Medical, and we provide portable, lifelong personal care records. My background is both engineering and medicine. I was an engineer before I went into medical school. So we developed our own GP record, and we became a global partner to an organization. And so we now have a lifelong personal care record for everyone.
Thank you, Stan. Vincent?
Hi, everybody. I'm Vincent Buscemi. I'm a commercial healthcare partner and the head of independent health and social care at Bevan Britain. By background, I spend a great deal of time helping clients to export their goods and services into new and emerging markets, as well as helping on a wide range of collaborations similar to PPPs and other types of partnership working arrangements between the public and independent sectors in healthcare.
Thank you, Vincent. Dirk?
Yes, my name is Dr. Dirk Richter. I'm Senior Advisor and Director Innovation Support with the Abu Dhabi Department of Health, looking at innovators, startups, as well as big corporate companies to come to Abu Dhabi to help us to further improve our healthcare system, as well as, of course, bringing investment and business to Abu Dhabi.
Thank you, Dirk. Ben?
Hi, my name is Ben Fennell. I've been working in insurance for about 15 years in Asia and in the Middle East, working both in M&A as well as strategy within joint ventures, one of which was in Vietnam, actually within a state-owned enterprise that previous company I was with that we invested into. And I'm looking forward to be able to speak with all of you.
Thank you. Richard?
Hello, so Richard Cantley. I work for Mott MacDonald, who are a global development, management and engineering consultancy. So I am the global health portfolio leader, and that team does a wide range of programs and projects across health and healthcare, from public health programs in low and middle income countries through to providing advisory services and healthcare consulting in relation to healthcare projects.
Simon? You're on mute, Simon.
Sorry. Thanks, Nishi, and hello, everybody. I'm Simon Swift. I'm founder and managing director of Methods Analytics. We are an end-to-end data services firm that grew out of an NHS team I ran for 4 years. And our focus is on helping people who make decisions, make better decisions through analysis and the development of meaningful, actionable intelligence.
Great stuff. So thank you, panel. You are a sterling panel. Just the wealth of experience across all of you is quite amazing. Just a quick introduction to me, for those who don't know me. I'm Dr. Neeti Paul. I'm a family physician by trade. I still see patients very occasionally, though. And I work with KPMG in the advisory practice globally on universal healthcare mostly. But I also chair the board of an accelerator incubator in the UK called Harbour. And I get to see quite a lot of interesting innovations across the world, including some ones in the infra space, but also in the PPP space. So, and I'd like to introduce the panel a question. Perhaps this is directed at either Dirk or Dr. Ibtisam. It's that whole question of public-private partnerships. Where do you see you can use these for delivery of healthcare? So I'm not just talking about bricks and mortar, like Steve said. Where do you see this landing? Anyone can take it on the panel, but I'd like to open this up with Dirk and Dr. Ibtisam.
Okay, maybe I'll start. Thank you. So I think PPP as a guidelines and law is being established in the Emirates of Dubai since 2015, and it's a law number 22, which you can find it within our Department of Finance website. And basically, that was the first start where Dubai government, within as well the federal government, where they were looking after so many of PPP projects where you can have a better kind of a collaboration between the public and the private sector. So therefore, and I think even because of the pandemic and as well as the current situation, there was even more appetite for those PPP projects where you can have a collaboration between the public and the private sector, not only in design and build, but however, even in running the services, as well as kind of like a distributing a risk between both the public and the private sector. So you have a better outcomes where you have a more cost-effective, better processes, mainly to ensure that you have a good focus and concentration on the patients, because at the end, you are basically, from the healthcare perspective, you are looking at the patients to be as a patient-centric, where you can basically provide them with the best kind of solutions. So currently we have done a couple of projects in Dubai, and recently we just signed kind of like an operational management between Dubai Health Authority and one of the private providers in the Emirates of Dubai.
Thank you, Dr. Ibtisam. Dirk, and then Richard, you may want to come in on this as well.
Yeah, I mean, if you look, of course, beyond the UAE and other markets, private partners can deliver excellent healthcare, and almost all of it. So there is, I think, the challenge, main challenge is, of course, any private partner needs to earn money, and that's pretty fair, since otherwise you don't deliver quality. I mean, well, why should it be different in healthcare? I mean, the main challenge for us, for regulators in Dubai and Abu Dhabi, elsewhere, is to really well balance this cherry-picking approach to only take the profitable patients, but this can be done with regulation. I mean, of course, those private partners have to deliver certain kind of healthcare, not only the most attractive patients. So that, I think, that's a challenge for a regulator, but other markets show you can do to really design regulation that helps. If you're a private partner, if you enter the market, yes, pretty fair. You are, of course, supposed to earn money, but we need to well balance the approach, so they shouldn't send all the non-profitable patients to the public sector and only pick the cherries. But that's something a regulator can do, in other markets show. So I think looking at Abu Dhabi, you have a number of big hospital groups like BPS, NMC, Mediclinic and others are also, of course, all of them also in Dubai. So they of course deliver a significant part of healthcare and works quite well. And we see them progressing more and more in more complex procedures like oncology and others. So looking back some years where many of them only looked at simple outpatient cases, we feel that they really progress. And I think that's very good. You need competition between public and private.
Thank you, Dirk. Richard, what's your perspective on kind of delivery of services by using PPPs?
Yeah, so thank you. So, there's been a lot of healthcare PPP projects around the world in various different models. Everything from the full privatization model through to much thinner private sector involvement, where it maybe just focuses around the design, build, and some hard FM. But I think the really interesting thing at the moment is really to look at, the future of healthcare, because it is changing so much. I think we're at a real juncture where we can really think in a much wider context in what PPP models might look like. So we're seeing the need for much more emphasis on preventative healthcare or preventative measures to really address some of the healthcare burden at source, to avoid just having a continual demand, ever-increasing demand on healthcare. And I think that with the need to design more patient-focused healthcare systems, digital disruption to healthcare systems, it really does put a different emphasis on how we should, bring together the best of public and private to deliver healthcare systems of the future. I'm a strong believer that the public sector always need to be the owners of the strategy. After all, it is them that are responsible for delivering health outcomes and health services to their populations. But by owning the strategy and thinking wider about where and when the best time to bring the private sector in, I think we can, come up with much, more imaginative PPP models, which actually get to the root of what we're trying to achieve, which is better health outcomes.
Thank you, Richard. And I think that opens up something. Simon, you had your hand up. Would you like to comment on that? And then I'll just move us on to the next question. Please go ahead.
So I agree with Richard, and I think there's a real opportunity to pick up and significantly broaden the PPP concept, to think about it from a population wellness point of view, and a true partnership between government, patients, and providers across the primary, secondary, and tertiary care space, and think about how can we use, and insurers, of course, how can we use and think about the different motives of each different part of that system and knit them together to deliver improved health outcomes, which are better for people, cheaper for governments, cheaper for insurers, and reduce the burden on providers, with everybody being compensated, focused on health outcomes and wellness rather than delivering sickness services. And I think the PPP model, with a value-based outcomes lens on it, is a really exciting way to do this. But I've not seen that very broad piece of thinking put into place yet.
Yeah, thank you very much. And I'll bring the insurance perspective, the payer perspective in a minute. Stan, did you have a comment on the kind of delivery of services?
I did, yes. And I think I'd like to take up the point that both Simon and Richard made, to widen this discussion, and Steve made right at the beginning, that it's not just about infrastructure. And I think in all, we've talked about patient-centric, in terms of prevention and so on. I think we'd all agree on the vital importance of data in healthcare. And I think we should be applying PPP to data as well, because there are very few countries that have a healthcare system that is exclusively public or private. Most are a mixture, but the citizen is neither public nor private, and lives in both worlds in most countries. So the citizens' data needs to include both public and private as it's relevant to both. So the citizens' data needs to be portable across public and private. And I believe strongly that citizens should be the primary data owner. And if they are, then the best way to ensure the availability of relevant data in both public and private is through the citizen having their own record that's portable and they take with them as they move between public and private. And that delivers the ultimate, it's a longer answer, but it's the ultimate in patient centricity that we've talked about and improving prevention. I think we need to move the center of gravity, that it's not about patients seeing doctors' data, it's more about doctors seeing patients' data. And I think the whole PPP envelope needs to encompass that.
Thanks. And I'm starting to get some questions coming in. I'm going to bring them in a minute. However, I'm going to broaden this discussion to payer models. I also come from an insurance world. Ben, you'd be pleased to know. So my question really is, so we've unpacked a little bit around these models don't need to be just infrastructure, just all of that. But we also talked about new care models. We'll touch on that in a minute. But I think what we're talking about also is who pays for some of these PPPs. So my question to you, Ben, would be, what's the role generally of a payer, but also particularly of insurers? Do insurers have a role here? I have a view on that, but I'm really happy to hear from you guys. Over to you, Ben.
Thank you very much for the opportunity. And I would say absolutely, from our perspective, having PPPs in place is one that's going to help drive affordability, and with any partnership, as we all know, having transparency, alignment of objectives, desired realistic outcomes that we think we can achieve. And most importantly, when you set these up, understanding what are the KPIs, how are they going to be able to do is keep it productive. With greater productivity going through, you're going to get greater efficiencies. That's going to create greater affordability. And that's where from our perspective, we're looking at it being able to say, okay, how do we create that affordability in the markets that we're in? That's the ultimate problem with whether it be a government or with a lot of our clients as well. So then, you kind of touched on how do payers play with this other than just paying the bill and wanting to have that affordability. I really do think we can also be joining and working in the private-public way, and this is really getting into essentially what within locally we've done with Damon, which has been really great, and you can see how this essentially a PPP has come together. But we've seen different flavors of this around the world. When I worked in Indonesia, they were rolling out BPJS. Here's something where you have a taxpayer model, government funding, but then also the desire for the citizens to pay, but continuously pay, not just pay when they need it. And so it's really important to understand the consumer behavior going into these models, the consumer practices that will happen, having the right framework in place very early on. Otherwise, you can get into a situation where the government's going to be taking more on that business case than maybe they were originally anticipating. And then also from a payer perspective, it's going to start coming upon the payer more, possibly getting into what Dr. Richter had also mentioned about the economics and making the economics then less meaningful for the private side. So not wanting to cherry pick, but wanting to be able to be a meaningful participant, but still being able to make the hurdle rates that are needed. So absolutely, we do support PPPs. We support it from the provider perspective, but also looking at it from a payer and saying, how do you bring this all together? And there are successful models and others that probably we could be working on improving as a team together.
I'm going to follow on with a question. Vincent, I'd like to hear your perspective on payer models as well, but I'm going to follow a question on, and perhaps you panel would like to think about that while we speak to Vincent and Ben more on this. Certainly on population health management and value-based care, we talked a little bit about that. There is also the models that I've seen evolve around the world where a payer takes the risk, like Sanitas in Spain, Ribera Salud, a few others that have happened on a whole population level, where the payer has taken the whole risk. There is a risk equalization fund that government needs to hold, obviously. So I would like to think about the payer models that evolve for population health management. And I'd like to hear more on that as well, because it's not just about what you commission in terms of a PPP, but it's also what you do on the payment side. So I'd really like to hear more about that. Vincent, over to you on the first bit of the question. And if you want to answer the second bit, really happy to take that as well.
Okay, thank you, Niti. I'll do my best. I think from my perspective, I see it from both sides. I see it both from the public side as well as the private side. And I think, there's a lot of evidence out there and a lot of research that's been done that demonstrates that there is a real impact on increased spending on health and sort of ultimately economic productivity. But there is in many places an underinvestment in healthcare, and looking at different ways and different payer models and financing vehicles to help close the spending and healthcare gap through either public finance or more widely with private finance or private capital is a challenge. It becomes more difficult these days with aging populations and a growing burden across most of the developed world with chronic disease. But in addition to that, there's now many more medical technologies that are coming to the market through med tech and life sciences that become more and more expensive all the time. So finding new models to pay for all this is really important. And we have seen in some cases, but not many, a shift away from the traditional, as I think Simon mentioned, the sickness model and paying simply for inputs to paying for outcomes. And whilst that happens in some places, payment for outcomes is rarer because many countries still pay and organize their healthcare systems and pay providers for the services they provide, not the outcomes that they help to generate. And so you have that volume of service model as opposed to an outcomes model. I also think that part of the new models for payment need to reflect the reality that in many systems, the payer versus the provider agreeing on what the priority outcomes are becomes a challenge, because that often goes hand in hand with two things. Firstly, the shift to trying to do more out of hospital in primary and preventative care, and to reduce risk factors that then lead to more expensive care down the road. But ultimately, it's agreeing on what those benchmarks are and then having simple measures to measure them. And that all comes back to data, and conscious that the sharing of data and the manipulation of data to track through and to support different payment models and financing vehicles is a challenge for many systems. And often, because it is a challenge, becomes difficult for providers to agree to bear a lot of that risk. And so it's trying to narrow those challenges. And I think PPP has a role to play in that, because it is, as we said, more than just infrastructure. And it can be about things like data collection, data analysis, that all of which help support whole population health management and the payment models that wrap around that.
Thank you, Vincent. And that was a very brave attempt at my very long question to you. So thank you very much for that. I'd like to just come back very briefly to Ben to respond to the kind of population health management models that I've seen evolve across the world, and actually in the US and New York State seen that as well, with some insurers taking on the whole risk-bearing risk, the capitation risk.
Yeah, and that is a continuously evolving model. I will go back to what Vincent mentioned. I think it's really important is around data. Data, being able to understand it, being able to understand also what the price points are, ultimately what the negotiations are coming down to. And you need healthcare systems and then a system in place where you're looking at it, where you do have this rich data, where it's of access, almost where third parties are able to provide that to you. That's what's worked very well in the US for us to be able to get to that right balance that's really needed. Ultimately, there's a role for the government to play here. There's a role for the providers, there's a role for the payers, there's a role for pharmaceuticals and other areas within the ecosystem, and then the client. And it's really important that we're able to get the balance of all of that. And what we have found in the US, if one side gets a little too greedy, whether that's the provider, the payer, the government, maybe they're trying to tighten things too much, things get out of balance. And then that's where you start to have, the issues. That's where everyone has to come back together and have that conversation again. But ultimately, and we're at an extremely great place now, just like you were mentioning earlier, of having great data, better data. As long as we can identify what that is and be able to collect that appropriately, probably at a government level, government's able to then be able to help with being able to do the pricing, maybe with a third party as well, their PPP structure. This is how we have seen the continuation be successful, both in the US and elsewhere. Hope that answer a little bit of your question, but very difficult.
It's a difficult one to answer where as Vincent talked about, with aging populations, where do you hold the risk? Can you transfer the whole risk or can you not? And do you need, like the Netherlands, do you need a risk equalization fund that holds some of that risk back that the government then administers? But it's an interesting discussion. Simon, I know you raised your hand. I'm just going to bring Dr. Ibtisam and Dr. Richter back into the conversation on a response from government on some of these models for the Middle East. So again, similar stories that we're hearing in the Middle East. You need the investment, and we heard from both of you. We want the investment, but also you want to look at value-based care, but also on a payer perspective, the governments that I know, a lot of them are trying to transfer their risk to somebody else. So where do you see that evolving, both in terms of payer models, but also on a PPP for the Middle East using some of these payer models?
Okay, well, Niti, it's a really huge topic and it has a lot of components, but let me just brief it somehow. At the moment, the services currently here, it's basically fee for services. Now, to transfer that for fee for performance, there's a lot of homeworks we really need to do. And basically the government is working. I'm just now focusing on the payment perspective, where you really need to bring the standard of care, quality of care, as well as from the e-claim itself. Basically, you need to monitor to ensure that you tackle and you have a good system where basically you can do a good pay per performance and to avoid as much as possible from the fraud and waste perspective. So therefore you have a good kind of an ecosystem in the payment mechanism. However, for the PPP projects now, from my experience and what we are working at the moment on various projects in Dubai Health Authority, whether it is a really infrastructure PPP or it's a operational management or it's a kind of a lease and operational concept. So in that base, there is an agreement between the investor and the government in terms of payment mechanism, whether it's the subsidies from the government itself or it's a payment, certain agreement on the package base, or it is basically a payment done through the government social insurance, and they could have a freedom by tackling certain demand, which is on the general network of health insurance. That means then they have certain agreement between the private insurance and the operator. So this is way where the investor can basically focus in terms of their returns. But from the government, at least they can guarantee number of volumes. And these volumes, as I mentioned, it's either could be a subsidies or it could be payment through the government or social insurance, or it could be an agreement between the public and the private within that contractual period. So we do have a various example, and we successfully completed one project in terms of an operations with one of the private provider in Dubai, and we agreed on the package model. And the other one, which is coming down the line, we agreed on certain fee model, which will be fee per pay per performance at a certain services that the private sector would provide to our patient, which is the government patients. Now, if it comes to the whole perspective from the governance perspective, where we really need to look at it from the bigger pictures, where you have the e-claim kind of a control towards the whole private market, this is of course a huge exercise that the government needs to take it over. And the good thing in Dubai that we recently have done something, which is we try to link the patient's data between the public and the private sector. We haven't done the whole exercise on the whole city, but we started to target major hospitals as well as some major clinics within the state.
Thank you, Dr. Ibtisam. Succinct as usual. Dr. Richter, over to you. You know, just
yes,
to localize this whole discussion would be really good.
I fully agree to all being said about data, and also to Dr. Ibtisam. Of course, things are quite similar. I mean, we have paid for fee for service for, I think, 13 years now in Abu Dhabi for health insurance for 13 years. So everybody's used to it. What I would like to add is the more cultural aspect, which is quickly becomes a political issue as well. Since, I mean, whatever kind of capitation you choose, whatever kind of risk sharing, it all requires certain kind of structured healthcare. As of today, everybody's going everywhere. So a lot of freedom, but people are used to it. Now, what we did in Abu Dhabi, or on the way to do, is to introduce a primary care model with a gatekeeper model. Is the very first step for it. But again, it's a critical issue. It needs to be done very, very well and so on. But if you go further, from my point of view, of course, I mean, you can study different models all over the world, and we still discuss which is the best one, but that's not something you need to customize to Dubai or Abu Dhabi or any Middle East countries needs. But the psychology behind telling people, look, tomorrow there is not you go just wherever you want to go, but you go to your certain kind of gatekeeper, and that's how healthcare starts. Otherwise, nobody can manage cost. I mean, if you continue like we do today, pay for services and don't structure at all, nobody will save money. I mean, the data will show, but just my gut feeling shows already. So that's clear, I think. So there is a certain component of what's the best model for which of the regions or countries. But basically, it's more about doing it very well, doing pilots, getting our patients or communities used to some kind of structured healthcare, having a clear pathway. You don't go wherever you want, but you go to whatever the gatekeeper is. I think that's another challenge. And I mean, if you look at NHS or others, it's in Europe, it's in very many places, it's clear it's much more restricted already. It's not that freedom we have. So this cultural change needs to be done very well. Otherwise, any model best all over the world will fail. So I think that's our discussions are more around how can we smoothly implement, one after the other in order to to be successful. Since there's always, wherever you are, a certain kind of political component. If you get too many complaints about what you do, hardly anybody can do in the end. So that's our the bigger issue for us right now is not choosing the best model, but really how to implement smoothly so that we are successful in the end.
Now that you mentioned the NHS, and I'll bring Simon, and Vincent has just raised his hand as well, wants to come in on this one. What people don't sometimes realize, the UK NHS primary care is the largest PPP in the world. So most GPs in the country, including myself when I was a proper GP, ran their own practices as a small business. And the government contracted with a proper contract, which was long-standing contract. It's long, it's not like 2 years or 3 years. So people can develop their practice in the right kind of way with the quality and outcomes framework attached to it. So I just wanted to bring that in to stimulate a discussion around primary care. It doesn't matter who delivers it. It's the contracting around what you deliver and the funding of it that becomes the really important issue. And we'll talk about that in a minute. So Vincent, Simon, you wanted to come in on this, and I think you probably want to come in on the kind of value-based comment, and then Vincent wanted to say something as well.
Thank you. There are quite a few threads which are swirling around, which I wanted to try and draw together, and will no doubt fail thoroughly to make clear. We've talked a little bit about the data being necessary. And I would go a step further in that the outcome-based contracts that we've supported between payers and providers, it's not just that they need data, but they need transparency, so that the payer, whether it's a government or an insurance company, has sufficient visibility of the data to be assured that the outcomes they're paying for are being delivered. Now, there's governance to be thought about and how you show them enough but not too much, because they're not allowed to see, you know, patient identifiable data. And the provider of care needs transparency to understand how their activity is being translated into contract KPIs and money in the bank. And they can see more of the data because it's patients they've treated. So we've developed a model which it certainly did that. And what that level of transparency generated was trust. And that's where I've always seen these kinds of outcome-based approaches fail, is a fundamental lack of trust between the people paying and the people providing. And data transparency created that trust and delivered the outcomes. There are lots of other things people have talked about New York models and risk pooling and many other things I could witter on about, but I won't. I'll stop there and let others carry on.
Thank you, Simon. Vincent, you wanted to come in here. I think, Richard, you had your hand up as well. Did Richard want to come in on this as well after Vincent?
Okay, I was going to make one of the points that Simon made about, you know, I get to see this from the perspective of a lawyer sitting around a negotiating table. And so ultimately, as Simon has demonstrated, in any of these models, particularly as you move from into value-based reimbursement and remuneration, and payers are ultimately asking providers to take on more risk and to deliver better services, ultimately or potentially with less resources. The data that sits underneath that is hugely important, but more important than the data, and as Simon says, the data helps this, is the relationship that exists between the people doing business with each other, because ultimately these are business relationships. And so that trust needs to be there. And quite frequently, payers, the commissioners in these systems, they will talk about risk and gain share mechanisms, when in fact, actually what they mean is the provider will take the vast majority of the risk, will share the risk with you, but the rewards may not necessarily be shared by the provider. The rewards will be with the commissioner in terms of less funding being paid over. And I think an important bit of all of this, which I don't know that we've mentioned, and forgive me if we have, is the whole issue of quality. Because ultimately, in these circumstances, what you then find in the negotiations is this intersection between, where value meets cost, you then have quality. And often commissioners are concerned that by sharing risk and reward, it almost incentivizes the provider to provide less healthcare and potentially at a lower quality. And whatever happens, it's important, I think, for the commissioners, the providers, and of course the patient, that the quality of the service, the quality of the care is not adversely affected by the payment model that's being used.
Thank you, Vincent. Richard, did you want to come in on that? And I'm going to move us on to the next question after this.
Yeah, I guess I was just reflecting on some of Simon's comments primarily and thinking about what potentially does go wrong and compromises some PPP arrangements. And, I believe, trying to transfer demand risk for healthcare to the private sector, you can never achieve that on a value for money basis, because who knows what the future holds, and who knows when we might get the balance better between mitigating the healthcare need to some extent. But it's much. It goes on to a more general principle, and I think and it's a bit of a textbook thing to say, which is the risk needs to sit with the party best able to manage it. And I think often where we PPPs potentially go wrong is that the contracting authority are quite comfortable with a bunch of risks that they are happy to manage. There's then a bunch of risks that the private sector are, best able to manage. And then there's typically a number of risks which the contracting authority don't really know how to manage. And so they often throw them over the fence and ask the private sector to manage them, when actually the private sector's in no better position and often in a worse position to be able to manage them than the contracting authority. And I think that can often undermine. You can't just throw risks over when actually the private sector can't manage them, because that is never going to lead to best value.
It's a really interesting question, that a really interesting challenge. We've had something come in the chat. I'll just read it out to you. Is there an argument to adapt health economic models with new health social economic systems as a basis for regulatory compliance too, not simply standards and law? Now, I think there's a moral argument here and there's a moral challenge here as well. But before we get into that, and I think it's a really interesting question that's being asked by a few people on the chat, I'd like to just switch the argument, to switch the conversation slightly, to really starting to talk about the public sector. And I think you touched on it, Richard, about not moving the risk, just throwing the risk over. And I think, Vincent, you touched on it as well from a contractual perspective. What does the public sector have to do to create capacity within its own system to be able to encourage public-private partnerships? But because in some of the health systems I've been in, particularly low and middle income countries, that capacity simply doesn't exist in the public sector to be able to think like that. So, and that's a question that I think we ought to be perhaps debating here. So I'll pass that to perhaps Vincent to start the discussion, and I'd like to bring Dr. Ibtisam, Dr. Richter into that conversation as well, and anyone on the panel who wants to take that on, and then to think about this question that's come in on the chat on the regulatory compliance side of it, not just being compliance and standards and law, but really using some modeling, social economic modeling for that. So over to you, Dr. Richter. Do you want to have a go on the public sector response, on what the public sector needs to do to build its own capacity?
I think first of all, it's more change management. I mean, it's really redirecting resources. I mean, I cannot talk about low-income countries, talking about many of the middle countries, UAE and the countries around us. It's really shifting resources and using a different model. I mean, first of all, you may have to shift some inpatient to more outpatient capacity. If you're successful, you have to, of course, change the mindset of people. I think it needs, this won't happen just by chance. So it's more really about government strategy and a clear implementation and a clear plan to do so. Since if you want to change minds and let's call it business models, operational models, you really have to be very clear, have a clear plan to work with people, change incentives for doing certain things or not doing certain things. So I think it's more about really a comprehensive plan and switching existing capacities, not really about capacity building, but really more about a clear plan. And of course, we need, as of today, we are in a much better situation than many years ago. We have data, we can work with those data. We have all analytic tools we would require in order to plan. So I think it's more really about a good plan, proper planning from a data perspective, as well as a change management perspective, how to do it, and then it should work. At the same time, the role of the private sector needs to be well defined as well. I mean, it's sometimes the ambition of the public sector to do everything ourselves, which is of course not successful in the long run. So it's really about planning and change management from my point of view.
Vincent, you had your hand up.
Yeah, I think looking at it again from the perspective of what happens in my world on this point, I think it starts at the macro level, and really, ultimately, is there a PPP framework within the regulatory and legal structures of the country in question? And if there isn't, then of course that needs to be sorted out and built up from the from the ground. But ultimately, assuming that there is that, at least successfully implementing any PPP is complicated. It's not something that's straightforward or easily done, and governments need to be committed to the PPP model, and then the capacity that's required really gets down into what I would describe as the micro level, because they need to be as a project, they need to be prepared, they need to be structured properly, there need to be people experienced in doing the transactions themselves. All of that requires specialized skill sets. So training is needed to build up that skill set, and then ultimately there needs to be support throughout the process, because in the context of these procurements, and that's what a lot of these will be, is the requirement that the public sector has procurement teams or procurement support through private organizations that can create compelling and appealing tender documentation and enable the whole of the project to be managed in a way that bidders want to say yes, they want to engage with it, and they want to see it through to the end. Often you see PPP models flounder because there's not a real clear articulation of what's required, when it's required, time scales drift, things become expensive, and all of that needs to be thought out before you actually, as a public sector body or as a country, launch into a particular program or particular project.
I totally agree with you on the sweating the small stuff, I call it. It has to be sweated, otherwise you can't do this. Dr. Ibtisam, do you want to respond from a government perspective, what you're doing?
Yes.
And I know you're doing some really great stuff in Dubai.
Yeah, it's honestly, Niti, it's not an easy thing, because you have a lot of engagement from different stakeholders, whether it's the public or the private sector. And within the public sector, you should have a very strong framework, and the contractual process should be very clear and transparent. And as well, you require a lot of buy-in from the people within the government sector itself, because you want to avoid as much as possible any resistance comes towards once you're trying to implement the project, because at the end it's a completely a change model, and you are trying to change from the routine what we used to do to something really new. And when we try to shift even the risk, we try to make sure to make our private sector comfortable, because if you make them jeopardize the whole things, basically the outcome will not be fruitful. So there should be kind of a win-win situation between the public and the private sector. And I think this is very important, whether this is a small value project or a large value project, which we are engaged now. And we're coming up, hopefully by end of this year, our first PPP project from the infrastructure, which is Cardiology Center of Excellence. And this is something, a very much unique model that I don't think so it's been much existent in the Middle East, because it's not just that the private sector are building, financing and designing, but there is a lot of elements of operational part of it as well. So here where you really need to have a kind of an agreement between the public and the private sector. Otherwise, it's a 25 years contract, and you have to be very careful. You need to anticipate and even project it in a proper way. So I always say transparency, proper planning, buy-in between the both sectors is very, very essential. And you should have a very strong contract methodology that you are working on it from the beginning, where you have an engagement of the private or investors within your workshop until you execute the whole project.
Thank you, Dr. Ibtisam. Richard, Simon, you want to come in on this?
So I think there are a couple of things. So I don't let many people know, but about 15 years ago, I did do a master's degree in health economics. I don't live in that world, and I don't do that work much anymore. I did way back when. But there are a couple of concepts which I think are quite relevant. One is impactability. We have to really understand how much we're able to impact the health of individuals and groups of people, and different interventions and the relevant impactability on different degrees of potentially development of the same condition. Because, sorry, it's really difficult for me not to be able to draw graphs and illustrate what I'm talking about. But for example, if we think about cardiology, people with congestive heart failure, there will be a group of people in the population living with congestive heart failure. There will be some where an intervention, graded exercise, with relatively mild heart failure can have quite a significant impact on their day-to-day exercise tolerance. Can they walk up a hill? Can they walk up steps? And their likely timeline to progression. So you can put an intervention in for that group of people who are impactable by a graded exercise intervention. You try and do that with people with much more advanced CHF, not only are you going to fail to make a difference, wasted money, wasted effort, but actually you could really upset some people who just can't tolerate it. So understanding the impactability of very fine segments of a condition cohort is important. And that leads me to the concept of, there's a health economic idea called the point of optimality. The more healthcare you deliver, the better outcomes you achieve. However, there's always a largely consistent level of adverse events, side effects, untoward interventions. And these two lines accelerate at different paces, and I really wish I could draw a graph. But eventually you reach a point where you're delivering the optimum value. You cannot deliver better health outcomes by treating more people, because the benefits become so small that the adverse outcomes outweigh the benefits, and you reach an inflection point in the curve. And it's understanding these kinds of concepts that the health economic lens on the problem can add.
So I'm going to bring us back to what the government then needs to do. So, and I'm going to throw this out there to the panel. And we've heard from the government, two folks on there from government who are doing this today live. And I know that some of these projects are live in the UAE. And Vincent has talked about what the government needs to do. So I'm going to throw this back to talk about what they need to do to create a market. So in my opinion as well, not just need to have the nuts and bolts, the sweating, the small stuff, of which data is a part, and Stan will talk about that in a minute, of which data is a large part of sweating the detail. And that's not just health data. It's also about all the economic data, the demographic data, all the data that you're going to need to project forward. So to sweat that small stuff to get that contract right. And I guess, Simon, your argument feeds into that. But really, I'd like to throw it out there. Richard, perhaps you might want to start this off, and Ben might want to input into this. Is in successful PPP models around the world that I've seen, governments spend quite a lot of time in the successful ones creating the market and getting entrants into the market. And I'll bring innovation in here as well, because we've seen what happened with COVID. We've seen that some governments invested in vaccines and some people didn't. But then the life sciences companies, the life sciences footprint of many countries now is saying, we need to do this because we may have another pandemic, which is quite likely. So how do we need to invest in our biotechnology? And then governments becoming very proactive about inviting people in to come and do those things for them. So I'm going to open this out here. Richard, do you want to start? And then perhaps others might want to come in.
Yeah, okay. I'll pick up on the first point you made, at the start of the session. And, for me, it's about the government owning the strategy. And to me, still around the world, you don't see a joined up approach between the public health preventative effort and the healthcare. And I think there's a huge opportunity for governments to look at that, a better balance between those two. And if you look at research, as an example, research around about the social determinants of health and the extent of the design of built environment on health outcomes, it's quite staggering. And for years, we've had, you know, an industry developing built environment solutions in cities and places without really understanding the health implications of the decisions they were making. And, you know, they weren't trained to understand the health impacts of those decisions. And so government really taking ownership of how are we going to get that better balance between that public health preventative measures and the healthcare solutions is really, you know, incumbent on them to do that. But, you know, when you then look at health outcomes in that much wider spectrum, you're then creating a market for the preventative, you know, the private sector involvement to deal with both sides of the scale, so to speak. So both in terms of how do we develop better places, healthier places, think about the health considerations and everything that we do in terms of infrastructure delivery, etc. You can engage the private sector in delivering, you know, more future-proofed and forward-thinking patient-centric healthcare systems. And then you've got data and things like that. So, you know, I think just by widening the context, looking at both sides of the balance, government owning the strategy, and then looking at the opportunities for the private sector to come and add value wherever the right places are across that whole spectrum, you know, that in itself, that approach would open up huge opportunity for you know, lots of different parts of the private sector supply chain.
I totally agree with you, Richard. There's also, Ben wants to come in here. There's also this whole thing about getting the providers that you may not know of, inviting them in and horizon scanning and bringing those providers in to want to come and work with you. I think, Dirk, you're doing quite a lot of work in Abu Dhabi around this. Ben, you want to come in, right?
Yeah, in touching on a couple of points that we've been hearing here, innovation obviously is there, health tech, med tech that's coming through, data. The one thing that's coming out, and you know, Dr. Richter spoke about this too, is the behaviors that need to change, the disruption that's happening, and then how's that also going to disrupt in a more political way as well in all the markets that we're in. Ultimately, you know, these various I would say providers out there, we all know and we understand that there are some that can be better than others. And, you know, where the government could play a role here beyond the vision, beyond investing into the right people being there, beyond putting in the right regulatory framework, is being unapologetic for substandard in quality, substandard in outcomes, and making sure that there is going to be continued efficiency gains as well along the way. And I think that's just it's something that's just underlaying there, particularly in markets where, you know, we have already laid out great, I would say, benefits for the consumer, benefits for the providers as well, and it's increased price points, and we're not really being able to then change the behaviors. So I get back to that unapologetic, you know, filtering out for lower standards, making sure that if there are low standards, then maybe the efficiencies that are going to come from med tech, health tech, elsewhere in a PPP environment can really help out in enabling that faster.
That's really, it's a really good take on this, and I'm getting some really good questions come in around this as well, which I'll put to the panel. I'm just going to shift the conversation again. You know, I've seen where PPPs fail. I've seen that in quite a lot of countries actually, is where the providers just simply don't want to be there. They don't want to take the risk, or they don't know about it, or we haven't scanned far enough or gone far enough to look for the right providers. So it's depending on the type of PPP you're doing. And some of the ones that Richard spoke about were kind of health and wellness ones, maybe not in the health space. They might be in the building and infrastructure climate change space that you might find some of these providers, right? So I think it's about finding those. I'd like to come back to the citizen. And I think, Stan, you started this conversation right at the beginning. You talked about the citizen very much and their data and how they own this. Quite a lot of innovation is currently coming from citizens themselves. And how do then governments include the citizens in this inclusive city around public-private partnerships. The one example that I often give is of the diabetes community, where the open APS community, where patients have designed their own closed-loop pancreas. So this is a community of practice for 600 odd patients across the world, done this themselves, because drug companies, med tech companies, governments don't want to take an interest in this, and they didn't want to wait. So a question to you, Stan, on this one: how do we include the citizen in the strategy, the development of PPPs, and also the design of what they want to see for their healthcare? You're on mute, Stan.
Oh yeah, after a year and a half of Zoom calls, we still make elementary mistakes. Okay. So much for a steep learning curve. Nitty, that's a great question. And it ties in with several. Let me hook it into a couple of the strands that we've been hearing already. I mean, Simon made the very good point that you can have an intervention for some people that's successful, it may not be successful across the board. What that tells me, and this reflects very much back to the citizen and being patient-centric with your data, is we need much finer granularity of the data than we currently have. We've talked about value and measuring outcomes and so on. Well, that depends what you're measuring. And in healthcare, like most walks of life, we tend to find those things which are easiest to measure. And because we can measure them, we then attribute significance to them rather than the other way around. And the Medical Research Council years ago did a big trial on measuring blood pressure to prevent strokes. And I've forgotten the exact numbers, but you had to treat hundreds of people to lower their blood pressure to save one of them having a stroke. Now, whatever else that tells you is, as a way of measuring stroke risk, blood pressure is a poor way of measuring stroke risk, but it's easy to measure. So we measured it, and then we turned the thing upside down and gave it significance. And I think perhaps one of the best value in healthcare, and it hooks right into the citizen, is maybe the best value in healthcare is restoration of full function to a patient after some kind of medical incident, especially a return to full economic functioning. Now that's much harder to measure, and that functional recovery can really only be captured from the patient, not the doctor. So after a hip operation, the surgeon may see you after 3 months, and the surgeon calls the operation success because 3 months later, your leg has not fallen off. You've still got your leg attached. So the surgeon is happy. But from the patient's point of view, what they want to know, value for a patient, is I'm back at work, or I can get up and down the stairs at home, or I can get out and do my shopping now, or I can get out to see my friends. And WHO has an internationally validated WHO Disability Assessment Schedule, a HWF, which is a great way of assessing functionality. So if we were to bring the patient perspective of how am I functioning, doctors are always interested in your blood pressure and the levels of your blood tests. Patients don't give a damn about any of that. Patients are function focused. So if we can bring in to outcome value, if we can bring in the patient's functionality to that. Now, just to pick up your point very specifically about diabetes, we've got evidence-based care pathways out there. The evidence-based care pathway says quite unambiguously, if you are 100% conformant with the evidence-based pathway, you, the patient, will get your best outcome, and best of all, the payer will get their lowest costs. But we don't routinely measure that. So if a population has got only 30% of their diabetics are conformant with the care pathway, the evidence tells us unambiguously that that population are going to get poor outcomes and it's going to cost a lot of money. If, on the other hand, you can, through interventions, increase the percentage of those patients who are conformant with the pathway, you know they'll save money and they'll get the best outcomes. And you don't have to wait 10 to 15 years. If after 1 year of an intervention, more people are now conformant with the care pathway, the research base tells you they will get their best outcomes. Now, if we're putting all that together, we have to take our courage in both hands and trust the patients to ask them the questions about their functionality, to trust them to ask them what they need to make a success, what they need to do, and what they want the system to do to help them get better outcomes, and capture that data at an individual person level in the highest granularity to feed up into your population health and into your outcome measures.
So a really nice answer, Stan, but I'll bring us back to how governments can include that whole patient voice in designing PPPs, because I think that's what I was, really wanting to focus on. They don't,
forgive me,
because it's highly political, right? PPPs are highly political as well. As we found in the NHS, it was highly political. And governments get very worried about, because the headlines usually in the Daily Mail are the NHS is being privatized. That's the headline you see. And I'm being deliberately provocative here. So that's the headline. If the consumer isn't behind you and the consumer's voice isn't in there, so the question for me is, how do you get that and you've answered that, Stan, to some extent, about how the consumer voice on data is there, but it's also about the planning and the strategy. I think, Richard, you picked up on that. So there's a question that's come in on the chat, and I wanted to put that to the panel. It's from Laurie Hawkins. It's a really interesting question. This conversation includes a lot about data. Would not a single source of truth of health and social care services, such as the example covering Australia, 8 state governments, be of value in reducing costs, given what it can for all stakeholders, and then combine this with the visual data analytics tools used by various government and private organizations for population health planning and costings? Now, I don't know about the one in Australia, so if anybody wants to take that question, it's a very detailed question, wants to answer that, over to you, panel. Who wants to have a shot at that? Simon, go on.
So my world is in helping people who make decisions make better decisions through meaningful data and analysis. I am aware of the Australian approach, where they've effectively brought together the entire country's population data into a single source of the truth, and then are using that to do many things. I don't know what, I've not seen that. I admit, Nitty, listening to you read that question out, I wasn't quite sure what the question was, the actual query bit of it.
The query is combining a single source of truth for health and social care services, not just health, which is what I think Richard also touched on in his answer. And given it what it can do for all stakeholders, combine this with visual data analytics tools that I guess consumers can see as well, so that it's not just yourself looking at it to drive PPP.
So that comes back to my point on transparency. So, and I know Dirk is looking at something along these lines in Abu Dhabi, but bringing together all of the very granular person level information about health and care, and I include all forms of care in that, and then using that to understand what is happening to who, when and where, and what impact are services having on health, and what are the issues in our population with regard to social determinants or health behaviours. So, for example, in the UAE, I know there's a specific issue with obesity and diabetes, which is, a population level problem that is much broader than a health services issue. This can't be tackled through health service intervention. Bringing that data all together and visualising it, so Dr. Ibtisam and Dirk and the governments can understand the problems at a macro level and design services. So providers can understand at a medium level likely demand and outcome of the services they deliver. And individuals can understand at a personal level how their behaviours do and don't contribute to their own health and that of their family and the population and the country they live within. So I think there are different layers of this theoretical, magical master visualization tool, visible to different people for different purposes, but ultimately making as much of it as possible visible to as many people as possible is crucial.
Yeah, got it. Understood. Point well made. I'm going to move us on. There's some more specific ones coming in, and there's one on, and I'm going to go back to my innovation question in a minute. Overutilization of healthcare services is common and evident in the public sector. I don't know where those assumptions are made from, but it's an assumption somebody's making. Is it also the case in the public sector in the region? Now, Ben, perhaps you could answer that. Perhaps Dr. Ibtisam or Dr. Richter could answer that.
So I think the question I heard, it's evident in the public sector, I heard at the beginning, and then also public in the region as well. I would say, just by the way that compensation models are developed in hospitals, that it can promote for such overutilization that can happen there. But there's also, if there isn't the right regulation in place, or there isn't the right staff at the beginning, such as within Australia, a great model, by the way, to be able to have that first point of care. Then, to be able to then give the guidance to be able to say, no, okay, you have a sore throat, you do not need to see the cardiologist. And being able to make sure that there is the right pathways. But yes, there's abuse on the public and private side. We've been able to see the data that we've been able to see. And I will flat out go back to compensation schemes. So if you are rewarded based on number of pharmaceuticals, number of labs, the number of imaging that you have in a given month, you're going to get that in the system.
For sure. And that's what payment-based results did in this country as well. So when you go to those systems, those overutilization kind of just rears its head. Whether it's true or not, we don't know. Any comment from Dr. Ibtisam or Dr. Richter about this? Overutilization in the public sector?
Yes, I mean, first of all, I mean, Dr. Ibtisam already highlighted earlier, if you pay for service, you have a strong incentive for providers to deliver more than required. I wouldn't distinguish between public and private sector. I mean, we see this in both sectors. For us, it's all equal. I mean, they're providers. It doesn't really matter whether they're private or public. If you don't have any kind of control over patient utilizing healthcare in terms of co-payment or anything, if you incentivize all providers to deliver services for fee, of course you have overutilization. This is one of the things we have to deal with, but I wouldn't distinguish between private and public. It's the same in both. Depends on where the patient goes, but of course it's a huge problem for us.
Dr. Ibtisam, you have said something before, please.
Yeah, exactly. I mean, I was agreeing with Richard about what's going on. It's basically not only public overutilizing, but it's as well in the private sector, because we do have shoppers within the system itself. So they go from one to another, and this is actually causing a lot of burden on the government. However, the overcome such a solution will be once we have an integrating system between the private and the public system. And I think that's will minimize the unnecessary request even from the provider side. So, that's might limit. And of course, you really need to have a good system like a GP, gatekeepers, and so on to just take off the unnecessary action that's happening towards and abusing the system itself.
Thank you, Dr. Ibtisam. So I'm going to move the discussion on into something that I think Richard touched on to start off with. I think Vincent talked about it. Lots of you talked about it. It was innovation, and I had a question right at the start of as we opened the webinar. We had a question right at the start. How can innovation and new models be integrated into the whole PPP story? So it's always difficult for the public sector when things are not proven to actually take charge of it and then say, I'm going to commission a public-private service based on this, on new care models. I think, Richard, you touched on some of this around health and wellness, but we've seen sudden adoption of digital health. We had to. COVID made us adopt it. And I've seen this in 44 countries that I've worked in. Suddenly, and in the UK NHS, 80% of all consultations moved online in general practice. I've been trying to do that for 20 years. No one paid any attention to me, but suddenly it all happened. And new models suddenly arrived. We are now in the throes of consumers wanting those new models to stay. So that's just one example. So to the panel, I would put, how is public-private partnerships going to respond to this new world we're seeing, and also the new innovations that are going to be required to make this world a healthier place and a better place for us to all be in? It's to anybody who wants to start that discussion. I guess, Richard, you did pick up on it. Would you like to start that discussion?
Yeah, I can. So, and again, it links back to, I think, my opening point about, there's so much change in healthcare going to happen, and a lot of that change is absolutely linked to innovation and digital disruption, for example. Now, then looking much narrower to PPP projects that I've been involved in over my time, and they've ranged in terms of the scope of that PPP, and I'm really referring to infrastructure PPPs here, just to draw an example. And some of those projects have really delivered amazing innovation by being set up right, by being structured in a way which really allowed the private sector to come forward with innovative ideas, which were then recognized and rewarded in the evaluation process. So the framework of the PPP bidding competition was set up to encourage innovation and really allow that innovation to follow through. I've seen other examples where the contrary has happened, and actually not, there has been very little innovation delivered. So if you take that really simple example about setting up your procurement, your contractual format, etc., to encourage innovation, when you then apply that to whole healthcare system and what PPP models might look like across that, or back to my original starting point, which is the whole range of preventative and public health interventions in healthcare, bringing these new innovative PPP processes and procurements in themselves, setting them up in the right way to encourage innovation, I think is what we absolutely need to do. Because, PPP can be restrictive in some formats, so it needs to be structured in a way which is flexible, encourages innovation, and can really make use of the best the private sector can bring alongside the skills of the public sector.
So I'm going to bring Vincent in here because he's the lawyer here and he knows about the regulation and it's sweating the small stuff. But a lot of, with my other hat that I wear, my tech innovation hat on, I get a lot of, I scan between 50 to 100 startups a month. And I get a lot of frustration from providers. The new tech, these are young, some of them very, very young. I feel so old when I talk to some of these guys, is that they're impatient. They want to get on with it. They can see their idea taking off. And then suddenly somebody says, have you considered regulation? Have you considered, as I often have to be the bad person who has to say this when they're trying to get me to take them into a different market. And I have to talk them through that. But governments are seen as a hurdle rather than a facilitator for some of these new things. So Vincent, over to you. How do you see this? Is there regulatory aspects that can be provided that make it easier?
Yes, I think that's absolutely right. When anybody wants to enter into a new market, one of the top questions they'll ask us as lawyers is, what is the regulatory framework and how much does it differ? And to what extent might our model or our delivery mechanism need to change in order to meet that regulatory framework? And I think it's a top question when you're looking at PPP structures, because often part of what you're trying to do early on through conversations and through engagement is obtaining that, I guess it's three things. On the one hand, there's the political will to do something. Then with project teams who can help deliver that. But then ultimately sat behind those things are the institutions that exist in country that will help, will need to be decision makers. And often that's where things tend to sort of fall down or slow down, because you're absolutely right. New, innovative med tech or new and innovative ways of delivering services such as digitization or whatever it might be, will often be ahead of the relevant regulatory frameworks. And so it's having that political will and the ability to flex those regulatory frameworks quickly enough to enable those new and innovative structures or delivery mechanisms to be brought in play in a way that the provider doesn't think that they're carrying all the risk. Because ultimately, they will need to be satisfied that, yes, if we do this over there, wherever over there is, that we are not in some way going to be breaching local regulations or local laws. We need that air cover, and the political will that exists or not is hugely important in giving that air cover, giving that protection or that certainty that a provider is going to be looking for.
Thank you, Vincent. I'll bring Ben in here. Ben, from a payer perspective as well, I've been looking at, you talked at the beginning about different financing mechanisms. We talked about, you've got capitated payments, you've got insurers taking some risk, you've got some insurers taking the whole risk in some cases. The regulatory mechanism for innovative financing, like blended financing, is that something that you need governments to unblock that to allow these innovative new methods to come in? So a different kind of provider can also enter the market, right? If you've got something like blended financing for healthcare.
Yeah, I would definitely say on the blended financing perspective, that would definitely work. And from our perspective, as we're looking at innovation, we have a whole team that is focused on innovation for international markets as well as within the US as well. We share that information. But then we also bring that to some providers and markets. There are some specific ones within Dubai where we're looking at and seeing, okay, we've seen this work in the US. We don't necessarily see this within the UAE right now. We do think something like this could help out in the future. Here's data that we do have to support this. The regulation doesn't support that at the moment. So, we are definitely, as a global organization, looking at how we can continue to innovate in the market for our customers and work with providers along the way. We do a lot more on the private side, obviously, versus on a PPP side, but definitely one that we would always consider, particularly if it's something that our customers or clients are going to as well.
Thank you, Ben. Dr. Richter, you wanted to come in and answer that from a government perspective, I guess.
Yes, first of all, of course, I fully agree to all being said, in particular, of course, the regulatory aspect. And so what we did in Abu Dhabi to solve it, we really created what we call Health Tech Hub. So Health Tech Hub is a dedicated team within Hub 71, which is our innovation ecosystem. It's a joint venture, Mubadala, Microsoft, SoftBank. So we really have a dedicated government team and also co-working space to work with health tech startups. All the things are clear. People come very enthusiastic, like we want to deliver something. And if you send them directly to government regulation division, they will come back with a message, you better come back in 10 years, maybe there's a licensing category. So what we really do working with those people to look at the business and operational model, where we need any kind of change in this model in order to meet regulation. And then we go together to our colleagues in regulation, thinking how can we make it happen? There's two things. First of all, we enable innovation. And secondly, we learn as an entity to regulate the future. We know there are many uncertain things and we somehow need to regulate the future. And the best way to learn about the future is to work with startups and innovators, since they are future. So it's for both sides. It's interesting. We saw a lot of change in mindset, but also really in policies, policies already being implemented just because our regulation colleagues saw what's possible in terms of technology, what can we do. It's still in infant stage. We are not at the end of our journey, but still there are already a lot of people being successful in the market right now. And of course, there's a certain kind of economic contribution, which is important for the UAE as well. But also in terms of healthcare, this direct interaction, sometimes like a translator job. You translate innovators' language to government and the other way around. And this is fairly successful. Now we are on the way to further extend. This is only one solution. When we're only talking about SME and startups, they're innovators at a bigger scale that need more than just something like this. And the other thing is we also work with our corporate partners, with hospitals, with health insurance, since it's already been highlighted as well. It doesn't really help if you only promote startups and the corporate partners, the big hospitals, and all of them are not able to work with innovators. Send them to procurement, asking for reference projects for the last 10 years, which doesn't help if the startup just was created 2 years ago. So it's really working with all partners. And we also included Plug and Play as one of the worldwide accelerators to help us to rebuild this ecosystem, which is now the second year. It was very helpful for COVID-19 since we immediately attracted startups to help us with a number of challenges. It's not the solution that fits all, but at least for SME, for startups, it's really helpful to not wait in your government office and let them come and tell them, very difficult, but really work with them in a very initial stage so that they can already start to modify their business model in accordance with regulation. On the other hand, regulatory hurdles can be mitigated.
They're very lucky to have you there to translate that for them, because a lot of them are terribly frustrated about not being able to do that. Dr. Ibtisam, any final word on that?
Yes, in DHA, Dubai Health Authority, we do have an innovation center, and we do have even future accelerator, where basically they accommodate those kind of companies, and they worked with them, and it depends on the size of the concept itself. And some of them, they can be adopted within our hospitals or our healthcare facilities, and some of them, if it's cannot be taken forward, we sometimes try to link them with the Dubai Science Park, where they take more mature kind of a concept, or from the equipment and pharma companies over there. And definitely our team in the accelerator and innovations, they work closely with our regulatory body as well as with us. So therefore we can facilitate. It depends on the whole concept and the project itself, and on the company, and what will add value to the government itself or to the market.
Thank you so much, Dr. Ibtisam. So we've got about 4 minutes left, and I'm going to give Steve the final word. So Steve, do join us if you're out there still. I'd like to thank the panel for being such a great panel. You've kept to time, you've been succinct in your answers, and you've brought such a wealth of expertise to this table here. I hope you've enjoyed the conversation as much as I have. I hope to keep on the conversation with you in the future. It's a very interesting subject, highly political. Governments can make or fall on PPPs. Your next door country, Dr. Ibtisam, the Kingdom of Saudi Arabia, where I do a lot of work, is also looking at these things quite closely. I'm sorry we couldn't have Manny on the call, but perhaps another time. So thank you very much for all your perspectives and all your response to my challenges. I hope you've enjoyed the conversation. Over to you, Steve.
Thanks very much, Nitty, and thanks very much to the whole panel for a fascinating debate. I think my takeaway from this is that PPP has been with us as a concept for quite a long time. It started off in the infrastructure space, but what's really clear is the fact that PPP could be so much better used and so much more commonly used for the delivery of healthcare, and bringing in, as I think one comment or one discussion that I was involved in the chat was concerned, bringing in the three heads, if you like, of healthcare, of the regulator, the private sector provider, and the insurer. It's almost, I think we coined the phrase PPIP as public-private insurance partnerships. So I think there's a really interesting thought there, and there's a hell of a lot more that we can do. There's a lot of innovation that can take place in this space. That's really clear. It's going to be fascinating to see how that develops in the future. I would like to point out tomorrow, for those of you that are interested, we have a breakout session on the Middle East and on market entry to the Middle East, for which Ben will be joining us along with Nitty. We also have, as Ibtisam mentioned there, somebody from the Dubai Science Park who's going to be part of that breakout session. So I hope to see as many of you at that session where you'll be able to join the call live and ask questions tomorrow. That call, if you're interested in that one, just pop your email address in the chat or drop me an email at steve@thetradeagency.co.uk and we'll get you an invite. Thanks, Ben. Thanks, Stan. Thanks, Simon. Thanks, Vincent. Thanks, Richard. Big thanks to Dirk and Ibtisim for giving that government perspective today. Really, really interesting panel. We have one more main stage session on Thursday for those of you who are interested in the future of healthcare in Africa. That will be taking place at 2 o'clock and should be a really good session.